Welcome back to the deep dive. Today we're doing something intensely practical. It's academic for sure, but it's also absolutely crucial for patient survival.
It really is.
We're structuring this session specifically for those of you preparing for the MD anesthesiology exams. We're going to be focusing on systems, on infrastructure, and maybe most importantly, on troubleshooting when those systems fail.
That's the perfect way to frame it. I mean, we're not just talking about the theoretical parts of an anesthesia machine. We're looking at the absolute foundations of safety.
Right.
And for the Gujarat University exams, topics like scavenging systems, the medical gas pipeline system, humidification, these are the scaffolding that patient safety is built on.
And if they fail?
If they fail, it can lead directly to those critical outcomes. We're talking about hypoxemia, cardiovascular instability. It's immediate.
I understand these are high-yield topics, but why do you think examiners come back to them year after year, not just on the written paper, but, especially in a Viva or a clinical setting?
Because they demand integration. That's the key. An examiner doesn't just want to hear you describe a scavenging system.
They want more than a list of parts.
Exactly. They want you to link its failure, say, an obstruction, directly to a physiological consequence. What happens to the patient? Barotrauma. What happens to the staff long term? That's what they're testing.
The ability to connect the machine to the body.
Precisely. You'll see questions on hypoxia prevention devices as a short note, or they'll weave it into a long answer about trauma resuscitation, where thermoregulation is critical. So our mission today is to really solidify that link.
Okay, let's start unpacking that integration. I think a good place to start is right at the boundary between the patient and the OR environment, the anesthetic gas scavenging systems. We need to get waste gas out of the room. What's the fundamental purpose here?
The purpose of the scavenging system, or AGS, is really twofold. First, you have to minimize staff exposure to waste anesthetic gases. That protects the people in the room and, the wider environment.
And this isn't just a regulatory checkbox.
No, not at all. It's a vital occupational health measure, and it's completely justified by the inherent toxicity of the agents we use, even at really low concentrations.
Okay, but hang on. If we're talking about just parts per million of waste gas, isn't the environmental argument often seen as stronger than the staff safety one today? I mean, serious complications in staff are very rare now.
That's a really perceptive question, and examiners love that kind of nuance. And you're right, with modern agents, the risk is low. But for the exam, you always have to anchor the discussion to the historical risks, especially with older but still very high-yield agents.
You're talking about halothane.
I'm talking about halothane, the classic required example. The toxicity we see in patients tells us everything we need to know about the potential risk to staff over a career of chronic exposure.
Okay, let's spend a minute on that then. Halothane hepatitis type 2, it justifies the whole system, and it's a guaranteed exam topic.
Absolutely. Halothane hepatitis type 2 is rare, but it's catastrophic. It's characterized by massive centralobular liver necrosis.
Which often leads to fulminant hepatic failure.
Yes, with an incredibly high mortality rate. We're talking 50%. 50. If an agent can do that to a susceptible patient after just one dose, you have to assume that any repeated chronic exposure is an unacceptable risk to staff.
So what's the exact mechanism? If I'm in a Viva, what do I need to say to explain that level of toxicity?
The mechanism is immune-mediated. It's all about how halothane is processed in the liver. It undergoes oxidative metabolism through the cytochrome P450 enzymes.
Okay.
And this process creates these highly reactive byproducts. Specifically, you need to use the term trifluoroacetyl metabolites.
Trifluoroacetyl metabolites. Got it.
These metabolites are electrophilic. They covalently bind to liver proteins, to the hepatocytes themselves, and they act as heparins.
So the body starts to see its own liver cells as foreign.
Precisely. In certain individuals, the body recognizes these altered protein complexes as an invader, generates antibodies, and launches this severe immune-mediated attack on the liver tissue. That's why minimizing exposure is so critical.
That makes the necessity brutally clear. Okay, let's talk structure. What are the key components in the flow path from the patient's circuit to final disposal?
Conceptually, you've got 4 parts: the collecting assembly, the transfer tubing, the interface, and the disposal system.
And we don't need to know every single screw and pope.
No, but you have to understand the physics. With the transfer tubing, for example, you have to remember that any bends or kinks in that tubing significantly increase the pressure drop per unit flow.
Okay, so that's a design factor that could cause problems.
A huge problem, yeah. Especially if your disposal system is passive.
And what's the single most important component in that whole chain for the Viva exam?
The interface. Without a doubt, the interface. This is the firewall. It's the mechanical and physical separation between the waste disposal system and the patient's breathing system.
You have to stress that firewall function.
You have to. The interface is essential for preventing the transmission of pressure back into the patient's circuit. It doesn't matter if it's positive pressure from a blocked line or negative pressure from an over-eager active system.
And if that interface fails, the consequences are immediate.
Immediate and severe. If it fails and you get high positive pressure, you're looking at barotrauma or volutrauma to the patient's lungs.
And on the flip side, negative pressure.
If the disposal system creates too much suction, you could cause lung collapse or even suck the gases right out of the reservoir bag, which means the patient isn't getting ventilated at all. You have to link the interface failure to those two critical outcomes.
So to summarize for the exam, scavenging protects the staff from things like immune-mediated halothane hepatitis, and the interface protects the patient from barotrauma or lung collapse.
That's the perfect summary. And in the long answer, you just briefly mentioned the types active, which uses vacuum, and passive, which uses the building's ventilation.
Right. Okay, let's move from getting rid of waste gas to where the gases come from in the first place. The Medical Gas Pipeline System, or MGPS. Let's focus on the most high-yield part of this. The machine's safety features that protect a patient if the MGPS fails.
Yes, this is critical. The whole theme here is preventing the delivery of a hypoxic gas mixture. The MGPS is reliable. It comes from central sources like liquid oxygen tanks, but you need redundancy.
Because pipelines can fail.
They can fail, they can be cross-connected, the wrong gas can be supplied, human error can always override protocols.
So before we even get to the machine, there are safety mechanisms built into the system itself, right? The connections.
Yes, and these are often short-note questions. You have to mention the standardized physically incompatible connections, the pin index safety system for cylinders, and the diameter index safety system, or DS, for the pipeline outlets.
So you physically cannot connect an oxygen line to a nitrous oxide inlet.
Exactly. It prevents those gross physical connection errors.
Okay, good. Now let's get into the machine's internal defenses. The hypoxia prevention device. This is a huge topic for the MD exams. What's the core principle?
The core function is to keep the inspired oxygen fraction, the FiO2, above a safe threshold, usually around 25 or 30%.
And an MGPS failure usually shows up as a pressure drop.
That's right. So the machine's fail-safe systems use what's called a pneumatic ratio regulator, or a proportional linkage. It's a mechanism that links the flow of oxygen and the flow of nitrous oxide.
So they aren't independent.
Not at all. If the oxygen pressure falls, the system automatically, proportionally, reduces or completely cuts off the flow of nitrous oxide. This makes it mechanically impossible to deliver a dangerously low oxygen mixture.
Can you break down the physics of that linkage a bit more? How does it guarantee that 25% minimum?
Sure. In a modern machine, the nitrous oxide supply pressure is actually routed through a special device that is itself controlled by the oxygen supply pressure.
Okay, I see.
So if the O2 pressure drops below a critical point, say 30 CSIS, that device physically restricts or just shuts off the N2O flow completely. It doesn't matter what the flow meter dial says. It's the ultimate technological safeguard.
And the physiological benefit of this working correctly is what our sources call the oxygen reserve.
This is such a great piece of integration for the exam. By increasing the FiO2, you create a massive reserve. Think about it. An adult's functional residual capacity, the FRC, is about 3 liters.
Right.
If you're breathing room air, the oxygen store in that FRC is maybe 500 milliliters. That's a very short time of safe apnea. But if the machine safety systems have kept the FiO2 high, say close to 100%,
You can fill that whole FRC with oxygen.
you can boost the oxygen stores in that 3-liter FRC to nearly 3 liters of pure oxygen.
That's a huge difference, almost 6 times the reserve.
Exactly. And that buys the anesthesiologist critical time. It gives you minutes to detect and fix an MGPS failure before the patient's saturation starts to drop into a dangerous zone. It's the direct physiological payoff from good machine design.
Okay, but what if the MGPS failure is catastrophic, where the machine's own systems fail? The result is hypoxemia, which brings us to the limitations of our most common monitor, the pulse oximeter.
This is an absolute Viva killer. You have to know this. We depend on pulse oximeters, on SpO2, but they have a massive limitation right when you need them most.
At low saturations.
At low saturations. Specifically, you need to know that in the critical range of 76 to 90% SpO2, their accuracy is significantly reduced.
And what's the specific error we need to remember for the exam?
In that range, 76 to 90%, pulse oximeters tend to read about 5% higher than the actual arterial saturation.
Wow.
So imagine your patient's monitor says 80%. You know they're hypoxic. But that 5% overestimation means their true saturation is closer to 75%. The monitor is giving you a false sense of security right when the patient is in crisis.
So MGPS failure leads to hypoxemia, but our monitoring failure means we might not know just how bad it is until it's almost too late.
It's all about layered vigilance. And you should also be ready to talk about other artifacts that make it even worse. Decreased perfusion, dark skin color, which makes it less accurate at low sats, and abnormal hemoglobins like carboxyhemoglobin.
Right. Okay, let's pivot now to the systems that manage the patient's internal environment. Humidification and heat exchangers. The goal here is managing heat and moisture loss. It's slower than a gas line failure, but just as profound.
The physiology is clear. Anesthesia messes with our normal thermoregulation. It inhibits the hypothalamus, and it causes vasodilation. And then the OR environment, cold fluids, exposure, just makes it worse.
And the respiratory tract itself is a source of that loss.
A significant one, yes. It's a documented site of both heat and water loss. The body has to warm and saturate every breath of dry gas we give it. That energy, that water, has to come from the patient.
So what's the clinical why here? Why is it so important to fight this, especially in a high-risk patient like a trauma case?
The sources are absolutely clear on this. Hypothermia increases mortality after major trauma. Full stop. So by conserving the heat and moisture that would be lost through the lungs, we are directly fighting a known cause of bad outcomes.
And we do that with either active humidifiers or, more commonly, passive humidifiers, the heat and moisture exchangers, or HMEs.
Right. The HME is basically an artificial nose. You place it close to the patient's airway.
How does it work?
On exhalation, it captures heat and moisture from the patient's own breath. Then on the next inspiration, the fresh, dry gas flows through it and picks up that stored heat and moisture. It's recycling the patient's own resources.
That's a great way to put it. Now, we need to connect this theme of heat and fluid management back to some broader metabolic complications.
This is a great integration point. Think about a major trauma. You're fighting hypothermia and hypovolemia. The patient needs massive fluid resuscitation.
Okay.
Now, if that fluid is buffered with weak ions, like citrate or acetate, which are common in blood products, the metabolism of those ions can cause a chloride-sensitive metabolic alkalosis.
That's a very specific chain of events. Why does that metabolic shift matter to the person managing the ventilator?
Because the body's natural compensation for metabolic alkalosis is to hypoventilate. It tries to retain CO2 to bring the pH back to normal.
But that protective hypoventilation can be a problem?
It could be a huge problem.
Yeah.
You risk driving the PaCO2 way too high, which can lead to CO2 narcosis. So a simple failure to manage heat and fluid balance properly has these complex downstream effects on ventilation that you have to be ready to manage.
It just shows how no system works in a vacuum. And HMEs, while they're good, do have their limits.
Of course. The main limitation is that any device in the circuit adds resistance and dead space.
Yeah.
A clogged HME can really increase the work of breathing, and you wouldn't use one if the patient has lots of secretions, for instance. You'd need active humidification then.
Right. Okay, let's move into what is probably the highest yield section for both exams and clinical practice: errors, artifacts, and troubleshooting.
Yes, this is non-negotiable. You have to nail this stuff. We should start with the machine and gas delivery errors.
Okay, let's jump right in. The most nuanced machine error involves the Desflurane vaporizer, the Tech 6 Plus.
Right, the Tech 6 is complex for a reason. Desflurane's vapor pressure is incredibly high, so it nearly boils at room temperature. A normal vaporizer can't handle it.
So the Tech 6 is heated.
Exactly. It's electrically heated to a very specific 39 degrees Celsius. This creates a high internal pressure of about 2 atmospheres in the reservoir.
And then it injects pure vapor into the gas stream. But what's the big high-stakes error associated with this, the altitude question?
The trap is that the Tech 6 is pressure compensated, but it cannot automatically compensate for changes in ambient pressure.
So it doesn't know you're at a high altitude.
Exactly. And the anesthetic effect is determined by the partial pressure of the gas, not the concentration percentage. So if you go up a mountain, the ambient pressure drops.
The concentration you set on the dial stays the same, but the actual partial pressure delivered goes down.
Precisely. To keep the patient anesthetized, you have to do a cognitive correction. You have to manually increase the concentration on the dial to compensate. It's a critical manual override for an automated system.
That is a perfect Viva trap. Okay, and let's just quickly reinforce the halothane vaporizer risk.
Yes. For the exam, halothane, Type 2 hepatitis, immune-mediated trifluoroacetyl metabolites, central lobular necrosis. High risk, high fatality, high yield.
Got it. Now let's shift to errors in breathing systems and ventilation, especially with ARDS.
Okay, the pressure volume curve in ARDS. When you draw this, you have to label 2 key points. You need a high opening pressure, it's called P1, just to pop open those collapsed alveoli.
But the therapeutic window is tiny after that.
Very small. A tiny bit more volume, which you can label P2, leads to overdistension and barotrauma. That's the classic Beak on the curve.
So lung protective ventilation is the strategy to navigate that dangerous window.
Exactly. It's all about limiting injury.
Yeah.
And you need to memorize 2 numbers for this. Keep the mean plateau pressure below 30 to 35 centimeters of water, and use low tidal volumes, around 6 mils per kilo.
What about recruitment maneuvers? We use them, but they're risky.
Very risky. You're applying a sustained, high-pressure 40 centimeters of water or more for 8 to 10 seconds. It can work, but you have to be watching for the immediate side effects.
Which are what?
Primarily bradycardia and hypotension. That high intrathoracic pressure crushes venous return to the heart, so cardiac output plummets. You have to be ready for that.
Okay, let's touch on a specific monitoring error. One lung ventilation.
OLV is a huge physiological challenge. And because of that, the normal relationship between arterial CO2 and end-tidal CO2 breaks down. The PET-CO2 gradient gets much, much larger.
Which means?
It means your end-tidal monitor becomes unreliable. You could have a normal PETCO2 reading, but the patient is actually becoming dangerously hypercarbic.
So you can't trust the capnograph alone.
You can't. It means you have a much lower threshold for getting an arterial blood gas to confirm their actual CO2 status.
Let's move to pharmacology errors. The classic one is succinylcholine in a burn patient.
This is all about timing. You absolutely must avoid giving succinylcholine 48 to 72 hours after a major burn.
Why that specific window? And what's the mechanism that makes it so lethal?
The burn injury causes a massive upregulation of extrajunctional acetylcholine receptors all over the muscle cells. These are receptors that are normally dormant. This process starts around 2 days post-injury.
So if you give acetylcholine,
You get this massive, sustained depolarization across this hugely expanded receptor field. This causes a huge uncontrolled release of intracellular potassium,
leading to severe hyperkalemia.
potentially lethal hyperkalemia.
Yeah.
It can cause ventricular fibrillation and cardiac arrest in seconds.
That's profound. Okay, next exam favorite, neuraxial opioids. The difference between early and late respiratory depression.
Examiners love this because it's all about pharmacokinetics and monitoring protocols. The key is lipid solubility.
So let's start with the lipophilic agents. Fentanyl, sufentanil.
Right. They are highly lipophilic, so they cross the dura and get absorbed systemically very quickly. This causes early respiratory depression, usually within the first hour. And critically, it's almost never seen more than 2 hours after injection.
Okay, so their risk is immediate but short-lived. What about intrathecal morphine?
Morphine is the opposite. It's not very lipophilic, so it stays in the CSF for a long time. This allows it to slowly migrate rostrally up the spinal cord to the respiratory centers in the brainstem.
And that causes the late respiratory depression.
Exactly. It can happen as much as 24 hours after the injection. And because of that risk, it mandates 24-hour respiratory monitoring for any patient who gets intrathecal morphine.
Moving on to intra-op monitoring, let's talk about assessing neuromuscular blockade recovery with the Train of 4. Why is just looking at it so unreliable?
Because the human eye and the human touch are just not sensitive enough. Subjective assessment, just looking for fade, is only reliable if the TOF ratio is less than 0.4.
And the danger zone is above that.
The danger zone is between 0.4 and 0.9. That's the zone of residual paralysis. You cannot reliably detect fade in that range by just looking.
So I might think there's no fade, but the patient could have a TOF ratio of 0.7 and still be partially paralyzed. What's the clinical danger there?
The danger is that their protective airway reflexes are still compromised. Their pharyngeal muscles are weak. They're at a huge risk of aspiration or upper airway obstruction after you extubate them. That's why you need objective monitoring.
Excellent. Let's finish the section with troubleshooting 2 common stressful scenarios. First up, the most common PACU problem, airway obstruction.
Right. In a recovering patient, the first thought has to be mechanical. And the most common cause is simply the tongue falling back against the posterior pharynx.
How do you tell the difference between partial and total obstruction?
Partial obstruction has a sound. It's sonorous respiration, the classic snore. Total obstruction is silent, but you'll see a critical visual sign. paradoxic chest movement.
The rocking motion.
Exactly. The chest gets sucked in on inspiration while the abdomen rises. That tells you the airway is completely sealed.
And the immediate intervention.
Oxygen first, always. Then the combined jaw thrust and head tilt maneuver. That physically lifts the tongue forward. If that doesn't work, you immediately insert an oral or a nasal airway.
Okay, second scenario. An unexpectedly high spinal or epidural block.
This comes from either too much dose or unusual spread, which you see in elderly, pregnant, or obese patients. The symptoms are pretty classic.
What are the key signs?
The patient will complain of trouble breathing, dyspnea, and numbness or weakness in their arms. But critically, nausea often comes before the hypotension. That nausea is your first warning sign that the block is climbing too high.
So you have to intervene at the nausea stage, not wait for the blood pressure to crash.
Absolutely. The intervention is immediate. Reassurance, oxygen, and then aggressively treat the bradycardia and hypotension with whatever drugs you need.
We've covered the systems and the errors. Let's now integrate this all under the umbrella of patient safety. How do all these failures converge?
They all converge on one final common pathway: hypoxemia. Whether it's a gas supply failure from the MGPS or too much resistance from a blocked scavenging interface, the end result is a threat to oxygenation.
And that's where the physiological oxygen reserve we talked about becomes the patient's lifeline.
It's literally the buffer that keeps them alive while you fix the problem. And when our monitors fail us, like PETCO2 and one-lung ventilation, you have to revert to the gold standard,
An arterial blood gas.
an ABG, or at least a very, very careful interpretation of the pulse oximeter, knowing its limitations.
And beyond the patient, this all comes back to staff health, too.
Right. A functioning scavenging system is the only thing protecting the staff from the same kinds of risks our patients face, just over a much longer time frame.
But the reality is, even the most advanced technology can fail. So how do we stress the importance of vigilance, even with all these safety systems?
Clinical vigilance and cognitive preparedness are the ultimate safety system. Safety isn't a feature on a machine, it's a process in your brain.
So using things like the ASA difficult airway algorithm.
Yes, using cognitive aids, having a preemptive plan for everything, especially for extubation and potential reintubation, because even the best machine can be defeated by a problem it wasn't designed to solve.
You used a great physiological metaphor earlier about the speed of the body's responses.
The body's protective mechanisms are incredibly fast and robust. The baroreceptors firing in response to hypotension, for instance. Our response as anesthesiologists has to be just as rapid, just as decisive, and just as prepared.
That's the holistic view examiners are looking for. Okay, let's drill down on the classic common exam questions and Viva traps.
Let's do it. We'll start with the absolute cornerstone question. Focus Q1. Describe the safety features in the anesthesia machine that prevent hypoxic gas mixture delivery.
And the answer has to include the ratio regulator.
It has to. The proportional linkage between O2 and N2O that guarantees a minimum FiO2 of 25%, even if the supply pressure drops.
Okay, next. Focus Q2. The management and prevention of type 2 halothane hepatitis.
Here you stress the immune-mediated mechanism, the trifluoroacetyl metabolites. Prevention is about patient history, and crucially, effective scavenging to protect staff.
And focus Q3. Compare and contrast early versus late respiratory depression with neuraxial opioids.
Lipophilic agents like fentanyl cause early depression in less than 2 hours. Morphine causes late depression up to 24 hours, which mandates 24-hour monitoring. It's a simple pharmacokinetic distinction.
Okay, now for the traps. First, Desflurane at altitude.
The examiner asks about the Tech-6 at altitude. You clarify the physics. The concentration dial is constant, but the partial pressure drops. The correct action is to manually increase the concentration setting to normalize the partial pressure.
Next, the advanced trap. Reversing a phase 2 block when you don't know the patient's cholinesterase genotype.
This tests your judgment. The safe answer is that the effect of neostigmine is unpredictable. It could make it worse, it could make it better. The only safe course is extreme caution, careful titration, and prolonged surveillance for at least an hour, even if they look okay initially.
So the key is to always link the system failure back to a measurable patient safety endpoint.
Always. MGPS failure links to hypoxemia, measured by SO2. Scavenging failure links to barotrauma, measured by plateau pressure. Always bring it back to the numbers.
We should also be ready to draw these things. What are the high-yield diagrams for the written exam?
3 visuals are key. First, the ARDS pressure volume curve. You have to draw it and label P1, the opening pressure, and P2, the barotrauma point, and you shade in the small therapeutic window between them.
Second, the HME schematic.
Just a simple drawing showing it in the circuit between the Y-piece and the patient. You show how it captures and returns heat and moisture to fight hypothermia.
And third, the hypoxia prevention system.
A conceptual schematic. A diagram showing the linkage between the O2 and N2O flows. Use arrows to show how a drop in O2 pressure forces a reduction in N2O flow, guaranteeing that minimum FiO2.
And what are the little labeling points that really get you extra marks?
Label the pressure targets. Plateau pressure less than 30 to 35. Label the molecular problem, trifluoroacetyl metabolites for halothane. And for an advanced point, label the spinal cord area most prone to ischemia, the mid-thoracic region, T3 to T9.
That is extremely thorough. Okay, we have covered the systems, the errors, the pharmacology, everything.
Let's consolidate it all into one final review.
Give us the high-yield bullet point recap, the 10 must-know points for the night before the exam.
1. Halothane hepatitis is immune-mediated, high in mortality. 2. Succinylcholine is contraindicated 48 to 72 hours post-burn due to hyperkalemia. 3. Desflurane needs manual adjustment at high altitude. 4. Lung protective ventilation means plateau pressures below 30 to 35. 5. Hypothermia increases trauma mortality, so humidification is critical. 6. Intrathecal morphine means late respiratory depression, so 24-hour monitoring is mandatory. 7. MGPS failure is protected by the ratio regulator, ensuring a minimum 25% FiO2. 8. Remember your pulse ox is inaccurate at low SABs, overreading by up to 5%. 9. PCU airway obstruction is the tongue, fix it with the jaw thrust. And 10. Subjective TOF assessment is unreliable above a ratio of 0.4. You need objective monitoring for full recovery.
That's a perfect synthesis. So how should a candidate wrap up a long answer on this topic to leave a lasting impression?
Your conclusion has to bridge the technology with your own brain. Something like this. The anesthesiologist must master the machine's safety features, as they are the first line of defense. However, final patient safety transcends technology. True mastery is shown by rapid recognition and structured correction of errors, understanding the physiological consequences of failure, from local hyperkalemia to global hypoxemia, and maintaining vigilance where no machine can substitute.
So what does this all mean? It means you're now prepared not just to describe these systems, but to troubleshoot them under exam pressure, linking every piece of equipment back to the patient's critical physiology.
And that's the difference between just knowing the content and actually mastering the application. Focus your final prep on integrating these failures into your resuscitation algorithms. Remember, vigilance is the ultimate safety system. Good luck.